Dr. John Ayuk.
Fantastic, thank you very much. So like I said, thank you so much for the kind introduction. And I'd like to start by thanking the Society for inviting me to do this talk, although it's with some regret that I'm having to do it over a virtual platform, as I was very much looking forward to visiting your beautiful country, in person to deliver this talk. So I do hope that the Society bears this in mind, and in future, once we are over the madness, which is coronavirus, extends me another invite to come, so I can come in person to deliver a talk at the Society meeting. So, like I said, what I'm going to do is just talk a little bit about how we manage acromegaly in the United Kingdom. As you've already heard from our chair, it's a multimodal management. We need multimodal management for this condition because of its complexity. Now, I always find that the best way to, put management guidelines into perspective is with a clinical case. And so I'm going to start off by introducing you to patient DR, who first came to our attention in May 2015. So she's a 27-year-old Afro-Caribbean lady who had a past history of craniovertebral decompression in 2009 for syringomyelia, had a history of polycystic ovarian syndrome, and in May 2015, on an MRI scan, she was incidentally found to have a pituitary lesion, and therefore was referred to our clinic as a pituitary incidentaloma. Having said that, as is often the case, with hindsight, when we looked at her scans, we noticed that there was probably a small pituitary lesion there going as far back as 2008. Because if you remember, she had syringomyelia, so she'd been having MRI scans of her head going back many, many years. So she attended the endocrine clinic, and when we saw her, she did have some classic acromegaly features like enlarged feet and mild coarsening of the facial features. However, she wasn't that symptomatic. She didn't have any sweating or snoring, a bit of facial pain. She wasn't particularly tall. Blood pressure was modestly elevated. She was on the oral contraceptive pill, so had regular withdrawal bleeds, and neuro-ophthalmology assessment was normal. We undertook a biochemical assessment, and as you can see, the relevant results are highlighted in red. So her IGF-1 was 3 times the upper limit of normal. And during the glucose tolerance test, her nadir growth hormone level was 42.9 micrograms per liter. So without a doubt, we'd established she had acromegaly. We went on to perform an MRI scan, and I don't need to tell you what that shows. Obviously, I'm sure you can all see she has a macroadenoma, which is extending to the suprasellar region and is abutting, but not necessarily compressing the optic chiasm. But also more troubling was she had extension into the cavernous sinus on the left. So now, obviously, if I was in front of an audience, I'd be asking, what's our next step? And so from our point of view, we asked that question, and this is a good time to go back to the American Endocrine Society guidelines for the management of acromegaly. Now, these are the authoritative guidelines and the guidelines which we all follow. And so, as I'm sure you all know, surgery is recommended as the first line treatment for acromegaly in most patients. And the surgical approach tends to be transsphenoidal, either using a microscope or an endoscope. In our center, we use exclusively endoscopic transsphenoidal surgery. And why is surgery first-line treatment for acromegaly? Well, it's because we have more than enough evidence to show that in the majority of patients, treatment, surgical treatment will lead to remission. Obviously, this figure is higher in microadenomas, as we all know, than in macroadenomas. But overall, in good centers, centers which specialize in the management of pituitary disease, you will find that the remission rate with surgery alone for acromegaly, with all tumors, combined micro and macroadenomas, tends to be somewhere between 60 and 70% and even higher. So it's certainly, worthwhile. And it seems correct that the first line treatment should be surgery. However, if you recall, I mentioned in Our Lady that there was invasion into the left cavernous sinus. The tumor was invading left cavernous sinus. And as you all know, what this generally means is that in patients like this, we will not achieve remission, because quite often it is quite difficult and tricky for the surgeon to go into the cavernous sinus with all of the important structures around. Trying to do too much can result in complications like carotid bleeds and so on. So from the very start, when we saw this lady, we counseled her and said, we will be undertaking surgery, but you are unlikely to, this is unlikely to result in complete remission, and we will probably need some form of adjuvant treatment. Now, sometimes the question is asked, well, if you know that you are not going to achieve remission, why are you going to undertake surgery? Why don't you just go with the next form of treatment? Again, the society guidelines are very clear on the fact that in a patient with paracellular disease, making total surgical resection unlikely, even then, surgical debulking is recommended because it will improve the response to any subsequent treatments. So basically what we normally expect is that with surgical debulking, the growth hormone levels will come down, and we know that growth hormone levels are directly correlated to the response to treatment. So we know that patients, or indirectly, so the higher the growth hormone level, the less likely any form of adjuvant treatment is to lead to complete remission. And just to reflect this, this is a small study which was undertaken by my colleague, Dr. Kavitaki, when she still worked in Oxford. And like I said, it's quite old and it's quite small, but I think it's the study which most elegantly shows the principle we've just been talking about. So if you look at this chart, they took 6 patients, and basically what they did was they treated them with primary medical therapy. So without surgery, they were started on somatostatin analog treatment, and they recorded how, what response they had to this treatment. They then stopped the treatment, and the patients underwent surgery. And after surgery, none of these patients were in remission. So they restarted the treatment. And what it showed was that at that stage, because the patients had surgery and the baseline growth hormone levels had come down, that when they were restarted on somatostatin analog treatments, the actual levels of growth hormone were actually, the patients responded much better to the somatostatin analog treatment. And in fact, 3 of the patients actually went into the region which we call, the safe growth hormone level. So it just goes to show that even if you do not think you can cure a patient with surgery, or we prefer to use the term remission than cure in acromegaly, if a patient is not going to go into remission following surgery, surgical debulking is still very worthwhile. Another question which sometimes arises is, well, how about we treat the patient with somatostatin analogs before surgery? We all know that in around 40% of these patients, the tumor will shrink. And so will the tumor shrink enough to mean that when the surgeon then goes in, they have a better chance of achieving remission? Now, this has been debated for many years and has been looked at in a number of studies. And this study here summarized the most appropriate studies which looked at this, because there were many sort of small retrospective studies which came up with variable results and were not really, didn't really inform this, answer the question. But they found 12 eligible studies, 5 of them randomized controlled trials, 2 prospective trials, 5 retrospective trials. And what they found was that in the short term, it did appear in some of these studies that the cure rate following pre-surgical treatment was better than in the patients who had not undergone pre-surgical treatment. But when these same groups of patients were revisited a year or 2 later, then actually what they found was the remission rates were exactly the same. So at present, we have no convincing evidence that pre-treating these patients with somatostatin analogs has any impact whatsoever on surgical outcome. And this is reflected again in the guidelines, suggesting that we do not treat these patients pre-surgically because it does not improve the biochemical outcome following surgery. What we do, however, know is that in some patients, especially patients who have significant comorbidities, pre-treating them with somatostatin analogs can actually improve their surgical and anesthetic risk. So in patients who have significant heart failure or significant sleep apnea, we will sometimes pre-treat them for 3 to 6 months prior to sending them for surgery. But this is not because we think it will lead to improved biochemical control. it's because we're just trying to improve the surgical risk. And so our young lady underwent transfemoral surgery in November 2015. And as you can see, the results were as expected. The patient, the bulk of the cellular and supracellular tumor was removed, but we still had residual tumor in the left cavernous sinus, which we had warned her is likely to happen. Very disappointingly, her IGF-1 level remained above the limit of detection of our assay. So although, yes, it may have come down from, I don't know, 300 to 200, in our eyes, we knew she still had significant disease. And so what's the next step? Now, I suppose because in our center, we have a lot of faith in our surgeons, and our surgeons are dedicated pituitary surgeons. They are not, standard neurosurgeons who intermittently operate on a pituitary gland. We have 3 surgeons, 2 of them are neurosurgeons, one of them is an ENT skull-based surgeon, but they are all dedicated pituitary surgeons. And so these are people who run pituitary clinics with us, attend pituitary multidisciplinary team meetings with us, and operate on pituitary patients every single week. So they are experts in surgery for pituitary disease. And so we often have faith, and we will often look at these patients in our pituitary MDT meeting and ask the surgeon, do you think you could go back and get some more disease tissue out? And if the surgeon says yes, that is often our very first step. Our very first step is to say, okay, redo surgery. Now, what is the evidence behind that? There is not a lot, but there is some good evidence out there. And this is one such paper which looked at patients who, following surgery, who had persistent disease, and the option was to go in for further surgery before thinking of other adjuvant therapies. And in those patients, over 50% achieved biochemical remission with their second surgery. And actually, there was very little excess morbidity associated with second surgery, and certainly no mortality. And so that's a strong argument, if you do have good surgeons, for saying, before we consider any other adjuvant treatment, let's see if surgery can achieve better effects. And so our young lady went on to have repeat transfemoral surgery in May 2016. And as you can see, the results, a lot of the tissue in the cavernous sinus was removed, presumably because it had moved more medially once the bulk of the medial tumor had been removed in the first surgery. So our surgeon was able to get a lot of the disease out. And there was an improvement in her IGF-1, but it still remained significantly elevated. And so the next step, and again, this is supported by the guidelines, is medical therapy. So the recommendation is to use medical therapy if after surgery, the patient is not in remission. Now, depending on what degree of, what degree of success surgery has had, there are recommendations as to which medical therapy to use. So in patients where the IGF-1 is still significantly elevated, the recommendation is to use either somatostatin analog treatment or pegvisomant, which is a growth hormone receptor treatment. If your IGF-1 is only slightly elevated, then actually it is worthwhile a trial of cabergoline first. And I'll explain why in the next few slides. And that's because cabergoline it's a tablet, it's simple to administer, it's quite cheap, whereas the other treatments are all injections. The other treatments are all injections and are more difficult to administer, often require healthcare personnel assistance. And so looking at somatostatin analogs, we know the first generation somatostatin analogs, lanreotide and octreotide, will achieve remission in about 20% of patients who are started on it de novo, so or following surgery. There is a second generation somatostatin analog pasireotide, which will achieve somewhere between 30 and 40% remission, but does come with its own issues, the main one being significant worsening of glycemic control. Now, I mentioned a trial of cabergoline in patients who have IGF-1, which is only marginally above the reference range. And the evidence behind that is from this meta-analysis, which was conducted by the group of Philippe Chanson in Paris, where they looked at the evidence around treatment of acromegaly with dopamine agonists. And what they found was if your IGF-1 was 1.5 times the upper limit of normal or less, then in fact you had a 50% chance of achieving IGF-1 normalization with cabergoline. And so this is certainly something worth trying. This is something we will do in our center. But what you need to remember, what often happens is patients with acromegaly will be started on cabergoline, and they will be put on the same doses as we use to treat prolactinomas. So they'll be put on 0.25 milligrams twice a week or 0.5 milligrams twice a week. And when that doesn't work, they will get referred to us as a tertiary center saying, we've tried cabergoline, it has not worked. Actually, in order to be able to say that with cabergoline treatment for acromegaly, you need to get the patient up to around 3 to 3.5 milligrams per week. That's the treatment dose for acromegaly. And it's only when you get to those doses, if the patient's IGF-1 remains elevated, then you say, actually, cabergoline is not working. We need to think about the next step. You're all aware of the treatment pegvisomant, which was the first growth hormone receptor antagonist to be developed for the treatment of acromegaly. It's the only treatment so far for acromegaly which does not actually target the pituitary, but actually blocks the growth hormone receptor and displaces growth hormone. So in these patients, the growth hormone level can be as high as it wants to be, but the way the pegvisomant works is it stops this growth hormone from binding to the growth hormone receptor. Now, in the initial studies, which were done in the early 2000s, you could actually achieve normal IGF-1 with virtually every patient you treated with pegvisomant. In real life studies, that number tends to be somewhere between 60 to 70%. But there are various reasons, both patient-dependent and physician-dependent, which lead to that. And, I still think if you take any individual patient and you use pegvisomant, you will be able to achieve, if you get to the right dose, you will be able to achieve IGF-1 normalization. Obviously, other factors come into play, like side effects of the treatment, but also a very important factor is the cost. Now, this is a very, very expensive treatment. And so even in the UK, our guidelines are very strict as to when you can use pegvisomant. This is a treatment which costs above £50,000 per year per patient to use. So as you can imagine, that is a lot of money. That's a lot of money which in, possibly developing countries would take away healthcare from a lot of other areas. This money will have to be taken from other areas of healthcare, which may be more relevant and more significant. And so there is a very, that does limit its use to some degree. And I'm sure we'll hear later from Colonel Shahid how the use of this drug, if at all, happens locally for you guys in Pakistan. And so just to summarize where we were. So this lady had presented to us, had transnodal surgery in 2015, which, did remove the bulk of the tumor, but she remained with active disease, had repeat transnodal surgery in May 2016, and which again did lead to an improvement in IGF-1, but she remained with active disease. And so the next line of treatment was medical therapy. And so we started her on somatostatin analog treatment and the injections. But unfortunately, she was totally intolerant to the side effects of this treatment and just could not tolerate it at all. And so we were a bit stuck now. We got to our next line in the algorithm, but this lady could not tolerate it. So what do we do there? And the recommendation from the society guidelines is that if you've got a patient who, following surgery, where medical therapy is either unavailable, unsuccessful, or not tolerated, then the next step in treatment is radiotherapy. And if possible, the recommendation is to use stereotactic radiotherapy rather than the old conventional external beam radiotherapy. And why is this? This is because we know that radiotherapy is actually very effective in managing acromegaly. In terms of tumor control, that's, it goes to nearly 100%. You'll be able to control tumor growth in acromegaly with radiotherapy. And this is regardless what form of radiotherapy you use, whether it's stereotactic radiosurgery, whether it's conventional external beam radiotherapy, or whether it's fractionated stereotactic radiotherapy. Hormonal control is not as good and tends to range around 50% in these patients, although the longer the time from radiotherapy, we know that it carries on working for many years. And in fact, there's evidence from our UK acromegaly register that if you go up to 20 years, growth hormone levels continue to fall. And as you saw in the guidelines, the recommendation is, if possible, you should use stereotactic radiosurgery. Now, what's the difference? Now, with stereotactic radiosurgery, what happens is the radiotherapy beams are actually concentrated through a collimator. So you can target one particular area with very high dose, because the beams coming from different areas go straight into the collimator and are focused on one area. It takes complex computer programs to program all of this. But as you can see from the picture below, you get a lot of beams coming from everywhere, but focused just on the pituitary tumor. And what that means is generally you can deliver this dose in one sitting. Whereas, as you know, with conventional radiotherapy, the patient has to come back over a 5 or 6 week period for daily small doses. What we're doing with those, with stereotactic radiosurgery, is we are focusing all of those daily doses into one, because we're able to focus it using this collimator. And again, what you can see is tumor control 100% in many cases, this actual biochemical control around 50 to 60%. And so with Our Lady, like we said, we got to the point where she was intolerant of somatostatin analog treatment. And we thought we need to treat her with radiotherapy. However, again, at our multidisciplinary team meeting, our surgeon said, well, actually, I can see a little bit of disease there, which is, which is possibly causing this problem. And if you go back to what we said earlier on, with any adjuvant treatment for acromegaly, what we are trying to achieve is the starting point of the lowest growth hormone possible. So our surgeons, we had an IGF-1 of around 115 nanomoles per liter. Our surgeon said to us, I can bring that down even further. And so he went in for a third surgery. Now, this is unusual. Most of our patients will not have more than 2 surgeries, but in this case, he went in for a third surgery and indeed was able to lower her IGF-1 even further. And so we started planning for radiotherapy. But if you look at that MRI scan image following the transfemoral surgery in 2018, actually, you can't see any tumor tissue there. So although we thought, she requires radiotherapy because IGF-1 is elevated, so we know there's tumor tissue somewhere, we couldn't actually see it. And so our first step was, we thought we'd still need to try and control her IGF-1 at this stage. Plus, even if we deliver radiotherapy, it will take over a year for that to kick in. And in that period, she will carry on having active disease. And so we made an application to our funding body, NHS England, for treatment with pegvisomant, which was approved. And so we started her on pegvisomant, and lo and behold, as you can see, her IGF-1 returned to normal. So what we then did was we thought, well, okay, we've got her on pegvisomant, this very expensive treatment. We've either got, going to have to treat her with this lifelong, or we're going to try and see if we can locate this active growth hormone secreting tissue and give her radiotherapy. And so what we did, now our colleague, Professor Mark Gurnell in Cambridge, has been very instrumental in developing a service. Well, it's still to some degree an experimental service, but where they use 11C methionine PET scanning to differentiate between focal disease or focal pituitary disease, active pituitary tumor disease, and normal pituitary in the cellular region. And so we actually sent her off to Cambridge to have this scan. And lo and behold, the scan did actually detect a small hypodense area in the left paracellular region, which fitted with where we knew her previous disease was. And so in February 2020, she underwent CyberKnife 25 gray delivered in one single fraction. And so what we're doing now is she remains on pegvisomant for now, but probably about nowish. So we usually give it 18 to 24 months, and then we withdraw treatment for a short while to see whether the radiotherapy has kicked in. If it has, then all good and fine. If it hasn't, we restart treatment, and then a year or so later, we try again. And that's where we are with her. And so that basically outlines the principle of how we tend to manage acromegaly in the United Kingdom. And I think that reflects in most developed nations how we would manage acromegaly. Obviously, there are variations in treatment across the world, and I'm sure I'll hear, different from Colonel Shahid as to how acromegaly is managed locally in Pakistan. But I just thought before I end this session, I'll just look at what else there is out there, what else is new, what else is topical in the world of acromegaly. So we all know acromegaly is associated with increased rates of mortality. But what is new is that we're finding we are getting better at reducing this mortality. So this is a meta-analysis which looked at some of the older studies, so ranging from 1970 to around 2007. And as you can see, the mortality rate there was 1.76-fold normal. And in the more recent studies, if you look, the mortality rate has come much closer to normal mortality at 1.35. There are various reasons for this. It's not just because we are, we're better at treating the acromegaly, but we are also better at targeting the risk factors. We know patients from acromegaly, with acromegaly, they die from strokes, they die from heart attacks. And so as well as treating their acromegaly, we are better at focusing on treating their cardiovascular risk, the blood pressure, the cholesterol, and that plays a role as well. But what we hope is at some point, this mortality rate will come to be exactly the same as the general population. There's the issue around discordant growth hormone and IGF-1 levels, and this is something we see not uncommonly in patients who we've treated with, patients with active acromegaly undergo treatment, and what we find is either the growth hormone is normal, but IGF-1 remains elevated, or less likely, IGF-1 is normal and growth hormone remains elevated. And in these patients, it's often a dilemma as to what to do. Is this patient in remission or not? And this happens in up to a quarter of patients with acromegaly, and an even higher proportion of those treated with somatostatin analogs. And obviously, the more sensitive our assays, the more the more the likelihood of us encountering these sorts of discrepancies. So what do we do about it? One, obviously, first thing you do if you find something which is not doesn't seem plausible, doesn't seem right, is repeat it. So often we will just say, okay, leave things as they are, repeat in 3 or 4 months. If it's still the case in 3 or 4 months, then our next step usually is to send the sample to another reference laboratory so they can measure it there and see if it's an issue with our assay, or if it's an issue with, more likely, the patient, either meaning that the patient does still have active disease, or the patient is one of those who sits outside the 95% centiles. We consider the clinical features, because if a patient has discrepant results and is feeling perfectly fine, then why do you want to do anything? Why do you want to intervene? We're happy to sit back and wait. And often what will happen is time will tell. Either these patients the blood test results will settle back to normal, or in due course, both levels will go up and we'll see that these are patients who do have persistent or recurrent disease. There are other factors which sometimes can influence the growth hormone IGF-1 relationship. So things like starvation, things like renal disease, liver disease, the sort of treatment they've had, and so on. There are various things. There's a list, and we look at those things as well. And if no cause is found, but the patient is well, then sometimes you just sit back and do nothing and just keep an eye on them. The other controversial issue is cancer mortality in acromegaly, and there's been a lot of work done on this. A lot of it, the results are quite controversial. One of these things which does seem to come up in many of the studies is that patients with acromegaly do have increased colon cancer mortality. But even there is some dispute as to actually how big that risk is. But there's enough evidence there to suggest that we do screen for colon neoplasia in patients who have acromegaly. And that is something that is part of our treatment regimen. So how about patients with acromegaly who become pregnant? Now, we've had a few, this hasn't happened a few times, And there is some literature around this. In particular, I like the literature from the Irish group. And the good news is generally it's safe. So if you've got your patient who you're treating for acromegaly and they come to you and say, "Doc, I'm pregnant," you generally do not need to worry. That's because pregnancy is actually a state of growth hormone resistance. So in fact, in most patients, you can stop the treatment. Sometimes patients do insist on staying on treatment, very rare, because as you know, most mothers, the first thing they think about is not their own health, but the health of the baby, and will say, "I don't want to take any, if there's any doubt, any controversy, I do not want to take the drug." And so it's safe to stop the drug. But if you continue the drug, again, in many cases, we do not have any adverse effects, although there have been 1 or 2 reports of intrauterine growth retardation in patients who were on somatostatin analogs during pregnancy. In general, what we would tend to do is we would stop the treatment. We don't monitor the patients. We don't need to monitor the patients. And the only thing that we do find is that sometimes there is an increased risk of gestational diabetes or hypertension. And finally, we talked about managing patients with pituitary disease in general and acromegaly specifically. It requires a multidisciplinary team, and it requires a good multidisciplinary team of people who have experience managing this condition, not people who, do general endocrinology or general neurosurgery and then double in this when they see it. You really need to be creating centers of excellence for pituitary tumors. And this is something which, the Pituitary Society put out a paper, a mission statement saying that this is something which we should all be striving for. And certainly now, particularly in Europe, you will very rarely find patients with acromegaly being managed anywhere other than centers for, dedicated pituitary centers where they've got experience in managing this. And this is always, like I said, it's always a multidisciplinary team, generally led by the endocrinologist, the neurosurgeon, but also involving the neuroradiologist, neuropathologist, radiation oncologist, neuro-ophthalmologist, and all of these people. We do joint multidisciplinary team meetings and joint clinics with all of these people present on one site. So the patients will come and have a one-stop visit where they come along to the clinic. They will see myself or one of my colleagues as the endocrinologist at the same time as they're seeing the pituitary surgeon. At the same time, just down the way, we have our neuro-ophthalmologist, and they'll leave us and go down there and then come back to us with the result of their neuro-ophthalmology assessment. And so we can often make it after one visit, we can give them a firm plan of how, what their management is going to be. And so this is what we need to be striving for, across the world. And so to summarize, surgery remains the first-line treatment for acromegaly, even if surgery will not achieve remission. Pre-surgical somatostatin analog treatment does not lead to improved outcomes biochemically, but can be used in patients where we're trying to improve their surgical or anesthetic risk. The mortality rate for acromegaly is improving with time, and we hope it continues to do so. Some patients will have discordant results, and we need to manage this individually in the ways which I showed on the earlier slide. The link between cancer and acromegaly remains controversial, but we certainly do continue to screen for colon cancer in particular in patients with active acromegaly. Some pregnancy is rare, but generally safe. And we all need to be striving to manage these patients in pituitary tumor centers of excellence. And thank you very much for your attention.
Professor H. Amir.
Thank you very much. My question is from John. It's sometimes so often happen here as well that there is intolerance, like was in your case, your curetide intolerance. Patient just couldn't tolerate it. And when that happens, what is your experience on changing the route of administration? Does it matter? Does it work? Or you just call it off a day?
For what is actually a very interesting question. Now, with somatostatin analog treatments, which are obviously the most common medical treatments for acromegaly, unfortunately, route-wise, we don't have many options. We're either using lanreotide, which is subcutaneous, or octreotide, which is intramuscular. Now, what we sometimes, so we don't really have an option of saying, okay, I'll use a different route, because we don't have oral octreotide, for example. Although, watch this space, there are a number of studies looking at oral octreotide treatment. So it may well be that if you ask me this question in 5 years' time, the answer will be completely different. At this stage, what we sometimes will do is we will swap from, say, if the patient's on lanreotide autogel and they're having problems tolerating it, we will swap to the long-acting octreotide to see if they tolerate that. I must say, in most cases, that does not help, because the patients if they're going to be sensitive, they're basically sensitive to the effects of the somatostatin, basically. And so whether it's the lanreotide or the octreotide, the same thing happens. And that's why with Our Lady, we were forced into thinking about the next step, because we knew we had to do something, but we could not keep the patient on this medication.
Thank you. Okay, Dr. Umar would like to ask the next question.
So John, thank you very much for a wonderful presentation. Now, having trained with you, and most of the Birmingham trainees are very much pro somatostatin after radio of the neurosurgery rather than radiotherapy. But I think working in Pakistan, the problem actually is that somatostatin or octreotide is so expensive that radiotherapy is much more cheaper. And I feel that in resource poor countries like ours, maybe radiotherapy might be or should be the second line therapy rather than the medical therapy, just purely from the cost perspective. So my question actually is, I knew you have done a lot of work on that, and your data was actually about, I think they were done on the radiotherapies that were done in 1990s, and the machinery have changed a lot. I think their technology have changed a lot. So what are your thoughts about now the newer radiotherapies like CyberKnife or Gamma Knife? What do you think about your data that initially 20 years ago showed the increased risk of cerebrovascular accidents or hyperpituitarism? Do you think with the newer machines, the chances of those side effects are less?
Thank you, Umar, for that question, which is always difficult when you get questions which involve insider knowledge. So obviously, Umar and I know each other well, and he knows my background, hence that question. So what he was referring to is some work which I did quite early on in my career as an endocrinologist, looking at the impact of radiotherapy on mortality in acromegaly. And what that demonstrated was that the mortality rates in patients who had undergone radiotherapy were much higher, I think fourfold that of patients who hadn't. And that was really the beginning of the move away from radiotherapy as a second-line treatment. That's the data which tended to be quoted. Now, since then, obviously, a lot has changed. Like Omar correctly said, this was data which we published in, I think, 2004. And the cohort of patients we've been looking at were people who'd had radiotherapy going back, from the 1970s. Things have changed completely, with the radiotherapy techniques now are completely different. It's much more conformal, much more stereotactic, even when you fractionate it. The computer programs which are programming this are a lot better. And so we see a lot less fallout of the radiotherapy to the surrounding tissues. Now, at the moment, I can't say for certain that what that means is these newer forms of radiotherapy are not going to have the same impact as the older forms. We hope so, because that's what the logic would suggest. But obviously, we're not going to know the evidence for that until 20 or 30 years from now. So, at the moment, certainly, we've even in Birmingham, we have gone back to using a lot more radiotherapy now than we did, say, 10 years ago, because we're recognizing that there are patients in whom radiotherapy can be helpful, despite the previous data we had, and we know we have pituitary radiotherapists in our MDT meeting who will tell us the pros and cons, they'll tell us the risks, they'll tell us all of that. So we're moving back to using it, and I think it is entirely reasonable that in areas where you do not have recourse to medical therapy for whatever reason. And if you recall, when I put up the American Society guidelines, it reflected that. It talked about where medical therapy is unaffordable, unaffordable, doesn't work or is intolerant, is not tolerated, that radiotherapy should be considered. So I think, yes, based on the local resources, radiotherapy is a good option. The radiotherapy which you deliver now is much more precise than radiotherapy we were delivering 20, 30 years ago. And, I think you have to work with what you've got. So I think it's entirely reasonable for, in many patients, radiotherapy to be considered the second line treatment. Again, in the UK, as you know, Omar, the patients don't have to worry about cost of medication because of the health service we have. So when we say we're starting a patient on a somatostatin analog, if the patient prefers to stay on that and not have radiotherapy, the patient does not have to worry about the cost of it. But I know in many places in the world, including the US, patients do have to worry about the cost of ongoing treatment. So yes, treatments where you may be able to, which will allow you to withdraw these expensive medical treatments, are entirely justified.
Thank you very much, Professor Najmul Islam sir.
I've got two questions. First is to the two speakers, Dr. Akbar and to Dr. John Ayuk. We discuss our cases in our Pituitary MDT before they go for management. And I have difficulty in convincing my neurosurgeons to go for surgery first in cases where the tumor is encasing the cavernous sinus. They say, I'm not able to cure the patient. Why are you subjecting the patient to surgery? Why don't you set them for radiosurgery directly? But I tend to tell them that even by debulking, that will make life easier for us to manage both by radiotherapy as well as by medical treatment. I'm glad that John gave the evidence, and they were asking for evidence from me. And John gave some evidence, but the evidence is weak. And I think it's more of an expert opinion. But again, this is the standard of practice. So do you have any comments to say, both Dr. Akbar and Dr. John, really on this?
Yeah, so from surgical point of view, I'll add something here, and that is, it comes again to the same thing that I discussed earlier. So if you've got a dedicated pituitary surgeon, I don't think he'll ever say no to a case of pituitary adenoma or acromegaly, because the first line is definitely pituitary surgery. So the main thing I would say is that you need a dedicated pituitary surgeon.
These are two dedicated pituitary
John,
surgeons.
do you want to add anything to that?
Indeed, I do.
They're very good ones.
I did, as you mentioned, I mentioned in my talk about the evidence for second surgery or even first debulking surgery if you are not going to achieve a cure. Now, although the direct evidence may be weak, the evidence that if you lower your growth hormone, your second treatment will work better, there's quite a bit of evidence out there. And I think that's probably what you should focus on when you're trying to prove to your neurosurgeon or your pituitary surgeon that they do need to go for the surgery. And I think the easiest thing is to actually quote the guidelines. The guidelines are there. The guidelines are obvious. That is what all the pituitary centers of excellence are doing. So unless your surgeon is saying, well, I know better than all the pituitary centers of excellence, then I think it's very difficult for them to justify not operating. And like Colonel Shahid said, I spend my time in my pituitary MDT meeting trying to stop the surgeons from operating a lot of the time, because our surgeons will just go in again and again and again if you give them the chance. They love going in there, and you can see Colonel Shahid's laughing because he knows exactly what I'm talking about. So yeah, again, it comes down to the fact that you need to be working with dedicated pituitary surgeons who and we've gone past the times when, as physicians, we considered the surgeons as the technical monkey. We'll tell you what to do. We'll tell you when to operate. You just stand there. We have really in-depth discussions with our surgeons about when to operate, when not to operate, and so on. So all I can say is that the evidence is there that debulking, even if you're not going to cure, will lead to better outcomes for whatever adjuvant treatment you use, be it radiotherapy, be it medical therapy.
The second question is to Colonel Shahid. In your series that you presented, the cure rate in your patients with macroadenomas were about 16%. Isn't that very low as compared to what we see in the international literature for cure rates for macroadenoma or remission rates?
After surgery.
Yes. Yes, what I saw in
Yes,
your
after surgery,
yes.
it was, I think, 27%. But it was lower after surgery, but I think that depends upon the expertise here.
Do you have a dedicated pituitary surgeon in your center?
Yeah, not dedicated. Neurosurgeons who are doing endoscopic transsphenoidal surgery, and some are doing microscopic transsphenoidal surgery was done in all these patients at least.
Okay.
But some are doing microscopic and some are doing endoscopic.
Okay.
But most of my patients were done by endoscopic surgery.
This is Dr. Osama, and I want to ask a question from Dr. John Ayuk. A wonderful presentation. I have two questions. A few of my patients, after them, both have biochemically and. Do you hear me? Hello? Do you hear me? Okay, both of our patients actually have clinical and biochemical evidence of acromegaly, but their imaging is normal. MRI pituitary done on these patients failed to pick up any adenomas. So my question from Dr. John Ayuk, what would be the management plan in such patients? How often we repeat MRIs in these patients, and since surgeons feel reluctant to go inside without any MRI evidence of adenomas, so what do you think? Do you have any experience on dealing with such patients? And my second question is regarding you remove the tumor, you do a histopathology of these tumors. Does the histopathology helps in making some decision on the treatment protocol, especially sparsely granulated adenomas or densely granulated adenomas? Does this make any difference in terms of treatment? Thank you.
Okay, thank you. Thank you for that very interesting, well, there's two very interesting questions. So the first one about patients who have, biochemically proven acromegaly, and yet on MRI scan, there's no visible tumor. And in fact, in some of these patients, you may even see a partially empty cellar. We've had a few patients with that scenario, and the way we've managed them has been quite different. And again, coming back to something Colonel Shahid said, one of the things you always have to do, and it helps when you're working in a dedicated pituitary center, is you need to have the confidence of the patient. You need to be able to reassure the patient that whatever you're offering them, the best treatment to the best of your knowledge, but also that you are willing and ready to take their what they think into consideration. So in our patients who we've had with biochemical acromegaly and clinical acromegaly, but no tumors, our approach has been very different depending on depending on the patient, basically. So in some of them, we've started them on medical therapy, and if they're in remission and they're happy, we've left them on medical therapy. Some of them have said, no, I'd still like to explore the surgical option. And we then do one of two things. If you remember, I mentioned in my talk the 11C Methionine Pet Scans, which my colleague Professor Gurnell in Cambridge he organizes. Like I said, it's still at the moment on a quasi-experimental basis, but it's coming more and more into clinical practice. And what these scans can do is they can, if you're lucky, pick out that the focus of disease activity within a normal pituitary. And that gives you an idea of where to go. In other cases, what we've done is actually our pituitary surgeons are quite happy going in for exploratory surgery because of, with their vast experience, they can actually recognize what is abnormal pituitary tissue when they go into the pituitary gland. So some of them have actually just got, we've agreed with the patient and they've just gone in, done full exploration of the gland and found the abnormal tissue when they see it. Sorry.
I would like to add something as well, and the reason is especially when you're doing, for example, Cushing as well. I mean, I tend to operate on Cushing, being a pituitary surgeon, and we do tend to find cases which Dr. Osama is. I work with Dr. Osama quite regularly. Is that you have got Cushing's patients where you can't find a microadenoma anywhere on the scan, but then you decide based on that where the tumor is lateralizing right or left, and then you go and do a hemihypophysectomy is one of the other things, which I tend to do. And also in this exploratory thing, because pituitary surgery in dedicated pituitary surgeon's hands is actually a very safe surgery. I mean, I'm not going to say numbers, but hundreds of pituitary tumors I've done over the years, and Alhamdulillah, the risks are very limited if you've been trained well and you're dedicated. So doing an exploratory approach in these cases, I think, like we do in Cushing's, is something on offer by a dedicated pituitary surgeon.